thanks to Letizia Moratti, Vice President of Regione Lombardia, and to the Fondazione Politecnico di Milano for this opportunity to discuss the impact of the pandemic on global health systems and the lessons learned from the experience of COVID-19, which has deeply challenged healthcare in both higher and lower income countries. Today, we are still living in a difficult time. The spread of Omicron is seriously challenging healthcare systems all over the world. For this reason, we must continue investing every possible energy on the vaccination campaign. Vaccines have made us stronger, saved thousands of lives, and allowed countries to restart their economies. We must insist in this direction without any ambiguity. COVID-19 has highlighted the vulnerability of our national health system. There are a number of lessons that we must not forget. One of these is the need to invest in our health system capacity and resilience, confirming our commitment to public health as a universal good. Italy was one of the first countries in the world and the first in Europe to face the spread of the epidemic and to have its health system heavily stressed. This crisis has dramatically refocused our strategies and energies on a new sustainable model in order to pursue health and well-being. Improving global, national and local health systems and investing significant resources in healthcare is crucial to support global socioeconomic progress. Therefore, health must not be considered as a cost. The money we put on health is the highest investment in people's quality of life. Today, we can invest even more because thanks to the European Union, we have the resources of the next generation EU that we did not have before. It is therefore time to relaunch public health policies and increase our investments. Health is the first global public good. Without it, there can be neither economic growth nor social development. The second lesson is the need for a better coordination among all the international actors in order to improve our capacity of prevention and response. These goals cannot be achieved without a stronger commitment to global solidarity, equity, multilateral cooperation, and effective governance. We need to transform the health emergency into an opportunity to strengthen both the global health governance system and the national health systems. The G20 Health Ministers meeting in September gave a strong boost to these priorities, defining a number of shared principles. In Roma, we called for the consolidation of international institutions in the health dimension and the strengthening of their architecture. Italy has contributed to launch of the negotiation of a new international instrument within WHO, and we are fully engaged in the present dialogue. The global vaccination campaign is the fundamental tool to fight this virus. Therefore, it is vital to invest in a donation policy that can favor countries with low vaccination rates. We donated 50 million doses so far, but we should do an extra effort. We must also increase equitable access to countermeasures, vaccines, therapeutics, and diagnostics, providing a framework for their development, manufacturing, and equitable distribution. The COVID-19 exposes a truth that is under the eyes of all of us. We have all realized that no one is safe until everyone is safe. The national states must have the courage today to give into the peace of sovereignty. Time is now. It can't be delayed any longer. Thank you very much.
Thank you. Thank you, Honorable Speranza. And I want to go on with the next presentation. Is, I think, a video coming from Dr. Letizia Moratti.
I greet the participants, Minister Mesa and Minister Speranza, and the distinguished speakers will present their reflections and the most advanced research on the theme of fighting pandemics, an event that we wanted to hold in Dubai, in the city hosting the World Expo, now at the center of international interest in innovation and vision for the future. Unfortunately, I am unable to be in Dubai with you, as given the current pandemic situation in Italy, and specifically in Regione Lombardia, I felt my place as healthcare assessor was to remain close to the citizens. SARS-CoV-2, as we all know, has had a devastating effect on our society and has brought us into a completely new situation. The whole world has suffered and continues to suffer the heavy effects of the epidemic. And in order to look to the future, as the title of conference suggests, with hope, we must learn the hard lesson that the virus has taught us. The pandemic has dramatically brought to light some of the weaknesses of health services throughout the world and has given us a very precise picture of the problems on which we need to intervene to improve the capacity of our systems to react. The Regione Lombardia carefully analyzed the problems that emerged during the entire management of the pandemic phase in order to get a precise picture of the critical issues to be addressed. Organizational, structural, logistical, and technological issues emerge that are now prioritized on which to act. Lombardy has therefore begun a process of improvement and optimization. And in the last months of 2021, the region completed the legislative process of strengthening its territorial health system, providing itself with a regulatory framework more suited to current needs, to future scenarios, to improving preparedness and the ability to foresee and prevent a healthcare crisis, although through the recognition and strengthening of territorial medicine. In Lombardy, we were the first to take action in this direction, creating the best condition for the use of recovery and resilience plans funds along the following lines. First, the new way of working in territory. Second, restructuring and modernization of hospital needs. Third, adaptation of IT infrastructure, and then improving data analyzing and implementation of telemedicine. The region has also decided to equip itself with a new useful tool, a research center on infectious diseases, allocating funds for its establishment. The center was set up to coordinate actions in a One Health perspective, to analyze problems, to define strategies, to improve the organizations and culture of the fight against infectious diseases. Lombardy, with its 10 million inhabitants, more than 70% of whom live in the densely populated Milanese metropolitan area, is unique in Italy and an urban and productive hub of international standing. Strongly connected with the rest of the country, with Europe and with the world by 3 airports, high-speed railways, and a very extensive motorway network. The region, due to its internationalization, is more exposed to being hit by global pandemic crises, such as COVID crisis. The high aging rate of its population, which is typical of Italian society as a whole, 45% of its inhabitants are over 50 years old, is another critical factor. The region, with its long industrial tradition, also has a strong vocation for scientific research. It is the Italian capital of the pharmaceutical, biomedical, and biotech industry, and it's home to an important network of university infrastructure with its university and 17 institutes for research and scientific treatment, one of all those in the country, 1/3 of those in the country. It is therefore the ideal place to host an infectious disease research center, both because of the need to protect a population statistically more exposed to pandemic risk, and because of the know-how already present that makes it one of the Europe health capital. We know that the fight against infectious diseases will be a major challenge in the future, and we must come to be prepared. The ultimate goal for all of us is to work to improve the health and quality of life of our fellow citizens. Today's speeches, which I will follow with great attention, will tell us where to go and where to intervene to make our efforts even more effective. Thank you.
I want to thank a lot Minister Speranza and Dr. Letizia Moratti for the kind introduction. And we can move on with the panel talks. And it's great honor to introduce Antonio Lanzavecchia from the Italian National Institute of Molecular Genetics. Antonio Lanzavecchia is a leading science in immunology and in new therapeutic agents against infectious disease and subjects. Please, Antonio.
Thank you, Andrea, and thank you for the invitation to speak to this meeting in Dubai. This title that you have chosen gives me the opportunity really to go back to almost 20 years of my research activities and tell you how we started to develop antibodies isolated from human memory cells. And because I'm talking about one therapeutic antibody, I have to show this legal disclaimer. Now, antibodies have been used for a long time, since the beginning of last century. These were horse antisera that Kitasato and Behring were using to treat patients infected with tetanus and diphtheria, and they were fantastic. They saved thousands of lives. And I have to remind you that convalescent plasma from in humans was used in 1918 with some success to fight the pandemic influenza, according to recent analysis. Now, but we had to wait until 1975 until we have finally the possibility of isolating a single monoclonal antibody, so to bring this new therapy to the new avenues. And only in 98 it happened that the first mouse monoclonal antibodies was introduced for human prophylaxis of severe respiratory syncytial virus infection in premature newborns. Now, the last few years have seen really an explosion of the use of monoclonal antibodies in therapy. There are about 100 antibodies for inflammatory diseases and cancer, and in the last very few years, there are now 14 antibodies have been approved for infectious diseases, primarily Ebola and SARS-2, SARS coronavirus. And 2 of these antibodies were generated in our laboratory, and I want to tell you a little bit more about it. So this is the idea that we developed in early 2000. This paper was from 2004. The idea is to identify individuals that give a particularly good antibody response, isolate the memory cells that have generated this antibody response, and screen millions of antibodies made by these cells to identify the best antibodies, and then produce the antibodies recombinantly. We can modify the Fc and then build up a medicine that can be used to treat a large number of people. We screen the secreted antibodies using functional assays. So, for instance, we can screen for neutralization, which gives you the advantage that you don't have to know a priori what is the target antigen. All right, so the first exercise was to isolate antibodies against the SARS coronavirus. This was the SARS that appeared in 2003. And this actually paper describes a method to isolate the antibodies as well as the first antibodies. And then we applied the same approach to isolate antibodies against MERS coronavirus. I remember coming here to Doha many years ago to see whether they would be interested to develop these antibodies. But the first antibodies that we had success with our collaborators to bring to the clinic was this Ebola virus neutralizing antibody, which we isolated, was called MAB118, and now it's called ansuvimab or Ebanga, and is now approved for therapy of Ebola-infected patients. So when given early after infection, mortality is reduced by more than 90%. So this is really a life-saving drug. So this is a bit a summary of what we have done. Some of the antibodies isolated have been in humans, and many are preclinicals. I see here our collaborators from Pavia, with whom we really worked for many years. But this slide shows you a second idea. Not only the antibodies can be used as a medicine, as a drug, but also can be used to identify the right target that should be included in a vaccine. Now, what are the desirable properties of therapeutic antibodies? I've listed them here: potency, breadth, effector function, half-life, and use in prophylaxis versus therapy. And let me go quickly through these points. This illustrates actually one amazing finding that we had again in collaboration with the Pavia group, that there were extremely potent antibodies that neutralize human cytomegalovirus. CMV is the primary cause of mental retardation and a terrible burden to the health system. And we found that these antibodies do not recognize the fusion protein, but rather recognize this pentameric protein. And then we made a pentamer vaccine and showed that in mice, this vaccine induces neutralizing antibodies at titers 300-fold higher as compared to those found in CMV infected patients. So by carefully choosing this molecule, in fact this pentamer, we can induce antibodies which are much better than those induced by natural infection. The second example is the breadth of the antibodies. So this concept of broadly neutralizing antibodies that I'm sure you're all familiar. These FI6 and FY1 are two antibodies that neutralize all influenza A viruses, group 1 and group 2, so I mean H1, H3, but also H5 and H7. These antibodies bind to a conserved site in the stem of the hemagglutinin molecule. So they identify, if you like, the Achilles heel of this molecule. And this is another antibody, MP8, that neutralizes 4 different viruses, RSV, MPV, but also the bovine and the mouse virus. And again, it binds to a conserved site in the prefusion F protein, and like the others, does not select escape mutants. So that's the advantage of choosing antibodies that recognize conserved sites. These antibodies, in addition, have potent effector function. And I have to say that the effector function is dependent not only on the Fc, but also very critically on the specificity on where the antibody binds on the molecules. And again, they do not select escape mutants, which is a very favorable property. Now, to finish off, effector function, as I said, is dependent on the epitope recognized, or where the antibody binds. So antibodies to the globular head of the hemagglutinin do not have effector function. And also can be modulated by Fc engineering, which is something we have learned when we made antibodies to dengue. Fourth point, the half-life of the antibodies can be extended. So injection antibody can protect now, modified antibody can protect for months. And finally, prophylaxis versus therapy. Initially, the RSV antibody was working only in prophylaxis, but now both the Ebola and the COVID antibodies really work in therapy. So when given to individuals which are already infected. And so I want to now briefly tell you a story about COVID. You are all familiar with the spillover of alpha and beta coronaviruses. There is nothing new. For many centuries this happened, but in the last years this happened more often, and now we have to face a tragic pandemic. And I just want to highlight this paper that the group of Davide Corti at UMass in Switzerland has published last year, describing an antibody that was isolated from a SARS-CoV immune donor infected in 2003. So this was still a vial that we had frozen, okay? But the idea to go to this individual was that because was infected by another related virus, this individual may have produced antibodies of higher breadth, so capable of neutralizing different coronaviruses. And in fact, this antibody has broad neutralizing activity against sarbecoviruses, many different viruses. Binds to a conserved glycan-containing epitope on the receptor binding domain, which is different from that seen by many other antibodies that bind to the so-called RBM, receptor binding motif, does not compete with ACE2, but again recruits potent effector function. And we think that this is an important property of therapeutic antibodies. And this just compiles many crystal structures of several such antibodies, the sotrovimab, so S309, the antibodies we isolated from the 2003 sample is here. You see it recognizes a different epitope as compared to many other antibodies which are potently neutralized, but very specific for SARS-CoV-2. And then Omicron came. As you know, this virus is continuously accumulate mutation. There are many different lineages, but Omicron came to a very big surprise because it really carries large number of mutations. In fact, Omicron has 37 mutations in the S protein, you see highlighted here, and 15 in the RBD, and especially in the receptor binding domain. As a consequence, most of current therapeutic antibodies have lost activity against Omicron. Sotrovimab, in contrast, has retained neutralizing activity. You see here the empty versus the filled circles represent the neutralization of wild-type Wuhan virus versus Omicron by sotrovimab and is equivalent here. And you see that for other antibodies, either the Omicron, which is in blue, the neutralization is gone, and for others is reduced by 50 to 100 fold. And this antibody is now reaching patients around the world with approximately 1.7 million doses, which have been either distributed or are going to be distributed. Now, I got this slide from my colleague Davide Corti, who has analyzed and characterized in great details not only the S309, which is the sotrovimab or Zebudi antibody, but also other antibodies that have broad neutralizing activity against coronavirus, especially this antibody here that actually is a molecular mimicry of ACE2. So it mimics ACE2. So this is to say that based on this preclinical data, there is possible to have a panel of broadly neutralizing antibodies that may overcome the SARS-CoV-2 antigenic shift. And with this, I want to close, but I want to tell you about an amazing story, which I like to call a clash of evolutionary titans, a clash between malaria parasite and the human immune system. Now, what we learned in these studies is that malaria has molecules that are about 200 genes, which are called rifins, which are expressed on infected erythrocytes and bind to human inhibitory receptor. So this is a pathogen that triggers inhibitory receptor to inhibit the immune response. So what happens is that in approximately 10% of malaria-exposed individuals, we find a new type of antibodies that are generated by insertion of the exons that contain layer 1 or LILRB1 into antibody genes. So these antibodies now are antibodies that contain the pathogen receptor. In a sense, they mimic the receptor. And these antibodies are very potent in blocking the parasites. We also find that these templated inserts are found frequently in antibody genes of European blood donors. So we think it's a general mechanism of antibody diversification. So that's the evolutionary clash, the clash of evolutionary titans. The parasites use 200 polymorphic and clonally expressed genes to evade the response. B cells with receptor insertion produce antibodies that the parasite cannot evade because the parasite has to maintain the binding to the receptor. And the question which I leave you is that whether there are other examples of receptor-based antibodies, and as you may guess, our answer is probably there will be. We have just to look for. Okay, so I have to acknowledge many people who contributed to the work. I told you it's about 20 years of work from my institute in Bellinzona, from VIR, which has been from the company that we founded and has now been acquired by VIR, an American company, our historical collaboration, and my new laboratory at the INGM in Milano, where my work is continuing. Thank you again for the invitation.
Thank you, Antonio, for super talks. And I'm very happy to introduce the second speaker, Professor Baldanti from the San Matteo Hospital in Pavia, University of Pavia. Oh, I'm so sorry. I'm very happy to introduce the next speaker, is Professor Sergio Brignani from the Milan University. He's a very good friend of mine. It's very honored to introduce Sergio. He is a very expert in the field of vaccine strategies, and vaccine development. His talk, his title of his talk is How COVID Changed Vaccination Strategies for the Future. Please, Sergio.
Thank you, Andrea. Maybe it was better if Fausto talked, because giving a speech after Antonio is really not the easiest task. So call with me because, this will go fine to make it easy. The title states what had happened in the last 2 years. In the vaccine world, very few things have remained as they were. And this is essential because of CoV-2, SARS-CoV-2. Now this, Anton already gave you the introduction, but it's a beta coronavirus. It's moderately to very highly infectious, depending on the original variant was 2.5 R0, so one infected person infected on average less than 3 people. Now with Omicron, it's between 10 and 12 at the highest level, like measles or rotavirus. And it causes only acute infection, but that's very important if you're interested in immune response. There's no chronic cases at all. 40 to 70% of cases, depending on the variants, are asymptomatic or post-symptomatic. It's not always easy to distinguish what is a person that's reporting very light symptoms with an asymptomatic ones. And we know that about 99% of symptomatic individuals resolve infection within 1 to 3, 4 weeks maximum, unless they're immunocompromised. And there's only about 1% of persons, usually at least 99% are over 60 years old with multimorbidity, and they die as happens with other infectious diseases of the airways. Antiviral drugs and neutralizing antibodies that we've heard exist that are quite effective. It is interesting. Depending if you're talking about drugs or drugs, that's one from Pfizer, very effective, or the antibody from Antonio, that is very effective, and they are very effective in preventing progression in already infected individuals, which is very interesting because having antibodies with therapeutic effect is not easy because we're talking about the virus that is already within cells, but they are effective. And there are 5 vaccines that have been registered, and doses are coming. And I'll tell you why this vaccine, 2 based on RNA, 2 based on viral vectors, and 1 that just arrived based on recombinant proteins and adjuvant, why they have changed the way we think about vaccines. Doesn't move. I don't remember what is the next slide, otherwise I would tell you what I'm going to. No, this is done. Okay. Yeah. Okay, the immune system essentially is based on 2 arms that goes in sequence. First, the innate immune response that has a feature of speed. It works very effectively in a few minutes, inducing inflammation with different types of cells or tools. And then you have a very sophisticated part, which is clonally based. That is the adaptive immune system based on B and T lymphocytes that have 2 features, specificity and memory. That is what you induce with a certain time. And this is what exactly we want to induce with vaccination, with specificity, again, a very specific microorganism, whereas innate immune response, you recognize patterns, but not specific microorganisms. You recognize specific microorganisms with vaccines, and particularly important, you must have memory because you should be able to counteract after a few years after you've been vaccinated. Now, in the case of SARS, these 2 parts of the immune system are quite interestingly interrelated. In the beginning, we know that the adaptive immune response in the viral response phase, which occurs in all of us, is very important because in 99% of us, it induces eradication and resolution of infection. Adaptive immune response is protective. You induce specific B cells and specific T cells. And at this stage, antivirals, monoclonal antibodies are effective in preventing severe disease. So it's a stage where whatever is hitting the virus specifically, either specific T and B cells or monoclonal antibodies or antiviral drugs, are very effective, and never give steroids at this stage because you inhibit the immune response. What happens in a limited number of patients, a limited fraction of patients, a few percentages, there is a switch from a dominant adaptive immune response to a dominant innate immune response in the lower airways and in the rest of the body. And de facto, you get a sort of autoinflammatory disease where you get a tremendous host-inflammatory response. You may have heard the cytokine storm. And it's a stage where innate immune response is dominating. It is harmful. It's not protective at all. And it's the stage where strong anti-inflammatory drugs like steroids are effective. And when if you give any monoclonal antibodies or antiviral drugs is useless because it's independent somehow on the virus because it's a sort of inflammatory response. So these are the two parts of the immune response that the virus is facing, is exploiting in the case of the innate. Now, these are the different classes of vaccines that have been licensed in the last 3 centuries. Although in the 18th century, I don't think it was licensing. When smallpox was invented, the smallpox vaccine. But what is important is to observe that 2 classes of vaccine, one in particular RNA and one that is adenoviral vectors, although an Ebola virus vaccine was existing but was used in a few thousand people, 2 new vaccines have been developed against SARS-CoV-2, adenoviral vector based and RNA based, and also a recombinant protein based. So essentially, we developed 2 new types of vaccines. If I say we, I mean the scientific community. And vaccines are protected because they induce adaptive immune responses, as you said, that is based on neutralizing antibodies produced by B cells, or CD4 T cells and CD8 T cells, the helpers that are key to all the immune responses we induce, and the killers. We know it, and this is interesting to know that if you look here, we have 3 types of vaccines, 2 of which, that is the adenoviral vectors and the RNA, induces all the 3 parts of the immune response, adaptive immune response, whereas this one, the recombinant proteins, induces only the antibodies and CD4 T cells, only these 2. And we know that these 2 parts of response are sufficient to elicit the protection at the same level than when induced CD8 cells. So we conclude that at the vaccination stage, you don't need to elicit CD8 killer cells to have an effective immune response, although obviously when you're infected, you need these cells. So why did I say at the beginning nothing would be as it was before? Because in the vaccine field, few disruptive points have emerged since we encountered SARS-CoV-2. For the first time, we developed very quickly genetic vaccines, adenoviral vector and mRNA, and I will tell you why this was really original. Vaccine development accelerated enormously from 8 years to 8 years was a record already, and before SARS arrived, to 8 months, which is something really incredible. In 10 months, worldwide vaccine production doubled. Till September 2020, all the world was producing 5 billion doses of vaccine for all the 20 type of vaccine we had. In 10 months, we more than doubled this. With 6 billion doses of SARS-CoV-2 vaccine, including the Chinese and the Indian vaccine, were made. We started a mass vaccination campaign of unprecedented dimension because we're aiming at several billion people per year, which had never been done before. And vaccination during pandemic time, that is really something immunologically very relevant because we are aiming, and we'll see with these shortened recall responses, more to an effector response than a memory response. I will tell you the detail of this. But these are just the 5 most relevant points that have changed the way we look at vaccine in the last 2 years. Now, when I say genetic vaccines, it's because so far all the vaccines we had, either killed virus, recombinant protein, purified virus, or attenuated viruses, you were injecting the protein, the antigens, or the carbohydrate, whatever was the antigens, and our body was recognizing non-self these proteins or carbohydrates or virus. Now, our body, with adenoviral vectors and RNA, is making the vaccine. So our cells are producing the protein. In this particular case, it's the spike protein. So, and therefore, we've changed the way. It's true that viral vectors were used for Ebola vaccines, but was really limited to a few thousand people. So we changed the way that our immune system is, and we don't fully understand yet whether the memory problem we have with some vaccine are related with the fact that we may, each of us, make our own vaccine because the proteins are made by our own cells. And it's important to acknowledge, particularly in the case of RNA, it was possible to make this vaccine because one person, Carrico, just 15 years ago discovered that RNA molecules, which are very are problematic because they are made to elicit an alarm, to induce an alarm in our body's immune system, unless you change uridine with pseudouridine, as she did, and then it was discovered that you could use mRNA without triggering an abnormal innate immune response, as you do when mRNA is recognized by our innate immune system. So these are the unique features of mRNA. I'm talking mostly about mRNA because other of our vectors for the time being have been partially or totally abandoned because of the problem we know about safety. They are highly precise, non-infectious, this transient, and non-mutational, all things that make this really, and in a few months or a few weeks, you can change the vaccine you have. So it's very flexible. The other one point that was made was making vaccine a disruptive point in 8 months. And this was really impressive because this was the standard way of developing vaccine, was a sequential cycle of events. I worked with Reno for many years in a company where first you start with the preclinical, then you look at the data, and then you ask for money just to move in an advanced preclinical development, then you move into phase 1, and you wait until you have the data, and then you analyze, because each of these stages has an intrinsic risk, economic risk of failure, and therefore you wait until you have this, and then at the end you ask the regulatory agency, because after you have all the data, you prepare all the documentation, required months, and then the FDA or EMA, are usually making you expecting for 10 months or 1 year before you get an answer, and altogether, if you are lucky, you could develop a vaccine in 7 to 10 years. What happened now, because the economic risk of failure was neutralized by public money, what happened was everything was done in parallel. If you look at the time and you ask the people who really developed it, when they were still learning something about the preclinical value of the vaccine, we're already planning for the phase 1. When the phase 1 was started, after a few weeks, immediately we're planning a phase 2, 3 together. And all of these stages, all the documentation was sent to the regulatory agencies for what was called as rolling review. So in the end, at the FDA or EMA, whatever was the agency, what was driving were the last data, but everything was already in their hands and the review was done. So, and with all this, in 7 to 10 months, and this was possible because with public money, all the risk of failure was neutralized in most cases. So, COVID-19 vaccine, efficacy in clinical trials, so region were all impressed. I'm talking very briefly about the efficacy and impact of the variant. That is what we're experiencing now. And efficacy, an important concept one should make immunologically and practically is that you can elicit an immune response that is sterilizing. In other words, you're protecting, you're stopping infection. There are viruses like oral poliovirus is preventing infection, but most vaccines we use are not sterilizing in the sense that you allow a certain degree of infection. So if you search for infection, as we are doing now with SARS-CoV-2, it's very difficult to get sterilizing immunity with the vaccine we have. We'll see the data. Whereas in the case of SARS-CoV-2 and also other infections, it is easier to get a vaccine which allows an asymptomatic infection, do not block transmission, and prevent disease. That is essentially what we're reporting with most vaccines, the SARS-CoV-2, at the level of 95-98% efficacy with the new variants. But, and these are the data, and these are from Italy, and this to show that vaccines work. Just to say that there's no discussion. You can see in this data from Italian data with Delta variants and refer to September, October, November of last year, 2021. And if you look at the incidence per 100,000 people in vaccinated and non-vaccinated individuals, in red are the non-vaccinated individuals, in blue are the vaccinated. You see here, if you look at infection, you see per 100,000 people, you have obviously a lot more people infected in the non-vaccinated, but still you can see some infection. In fact, we know that against Delta that was dominant at the time, the efficacy in preventing infection was at the top of immune response, 60-70%, and if you wait a few months, even 30-40% only. But if you look for hospitalization, or even worse, for access in intensive care unit or that, you see that unless you look for people that are over 80 years old, that are those that are dying nowadays in the vaccination, in the vaccinated group, you see that you have a tremendous protection from vaccine that is from 95% increasing up to 98-99% in people that are 60, 70 years old. So vaccines are very effective against the Delta variants, and the same data are reported now against Omicron, with the advantage that Omicron is less pathogenic than others. And now we see the impact of SARS. If you look at the variant, you should look for three things: the diffusivity, pathogenicity, vaccine efficacy. And in the last year, we experienced three variants that were clinically relevant: Alpha, Delta, and Omicron, or English, Indian, and South African, as you prefer. But what is important, think of future variants, you need to have a variant that is more infectious than the existing one. Otherwise, even if it is more aggressive, is escaping vaccine immune response, I mean, we don't care, as long as it does not take the diffusivity of the existing variants. In other words, Omicron that has an R with 0, 12, is very difficult to imagine a variant that will be more infectious, although I mean, these viruses surprise us a lot. So one thing we should always look is how diffusive, how infectious, what is the R with 0, and then look at all the rest. Because we don't care at the beginning about aggressivity, pathogenicity, and vaccine efficacy, but look at how effective is, and here is how a variant is displacing the others. And we're seeing this is one towards Alpha, Alpha towards Delta, and Delta, okay, Omicron is not, it was just appearing, just we agree in South Africa, but in a few weeks it's making 100% or 98% in most countries. So it's very, very diffusive, Omicron. And if you look at and this is interesting, if you look at protection against Alpha variants, you see that the infection against Alpha with the Wuhan-based vaccine is very high, it's 95%. Instead, if you look at Delta and Omicron, it's 70%. So you're losing mostly protection from infection, which means since neutralization of infection is based on neutralizing antibodies, it means that you can easily escape neutralizing antibodies, but it's very difficult to escape T and B cell responses against conserved areas that are not related to entry of the virus. So if you prevent the disease, essentially you are inducing a response that is killing infected cells and not preventing infection. And this is what happens when Delta appeared. You see that infection was really immediately down, whereas protection from severe disease was still high. And based on this data, in Israel, they started immediately with the fourth vaccination when Delta was still dominating. And Omicron arrived. Omicron is an interesting variant, obviously. It has a transmissibility that is at least twofold higher than Delta. From 6, it jumped to 12, R with 0. So one infected person is infecting 10 to 12 other people. The disease severity is reduced to about 70-80% compared to Delta because it tends to stop in the upper airways. But since it's so infectious, you still have a severe impact from the clinical point of view. And the vaccine efficacy is similar to Delta. It means that people with 3 doses are partially protected from infection, but highly protected and from severe disease. And I finish with 3 slides on the booster shots, because this is something which has been very addressed in a confused manner for several months. In the vaccine world, I mean, the 3-dose schedule, if you escape from the vaccine, from live attenuated virus, which usually is 1 dose or 2 doses, all the rest of the vaccine based on recombinant proteins or kill virus are based on 3 doses. With the first 2 doses, they usually are closer, you induce a strong effector immune response. With the third dose, 6 to 12 months after, you induce a strong long-lived response, a memory response, which on average requires a boost 5 to 10 years after the last dose. And this is true for all these vaccines and even other that are used. So in the vaccine world, it's normal to have a 3-dose approach. And this we know, that the most durable response are those with 3 doses, with the third dose space at least 6 months. And we know that the first 2 doses induces an effective response. And what I write here is that during explosive pandemia, it can make sense having closer responses because you induce a lot of effective responses and you don't care about something that is already there. You don't need memory if you are in the middle of pandemia. But it is interesting for the consequences. For the consequences it will have. That is, sorry about that. And the consequences are that the COVID vaccine were developed with 2 doses, not because people wanted 2 doses, but because if you are in the middle of pandemia, that only in Italy was killing 20,000 people every month, you start with a strong effector response because if you want to register with 3 doses, vaccine would have arrived 6 months later. So that's why we started with 2 doses and then the third dose was inevitable. But when the immunity started waning after 2 doses, the question was serious because variants had changed, and the question was whether it was just a decline of effector response in the absence of a long-lived response, memory response induced by the third dose, or whether it was an immune escape of Delta variants. And the answer after a few months was just a waning of effector response, which was corrected with the third dose. In fact, in Israel, with the third dose, they restore immunity to Delta. So it was not with the same vaccine. And this was a very important, and we know that even with the 4th dose vaccine, this didn't change. So it didn't change the effect on infection, but you just collect the same data on protection from disease. So we're sure that both with Delta and Omicron, the decline would serve because in between the 2nd and 3rd dose was due to a waning of effector response in the absence of long-lived memory cells, which were boosting with the 3rd dose. So it remains now to see whether after the 3rd dose, as it is with the other vaccines, we may wait, since we're not going after protection from infection, but protection from disease. How long will we be protected from disease? It's a matter of time. And we'll see, because Israel will have already, in a few months, we'll have 8 months from the 3rd dose, and we'll see if they start getting infected again with Omicron. Obviously, we don't look for protection from infection. There are some data coming out, but still very preliminary and limited in number. So I finish with the disruptive points that I presented you with. And with Omicron, the disorder under the heavens is high. So the situation is excellent, Mao Zedong was saying. We're trying to vaccinate the whole world in 2-3 years. So 20 billion doses should be delivered in 2-3 years, which is a terrific effort. We're experiencing something which was never experienced before at this level, which is mass vaccination during an explosive pandemia, which immunologically is very relevant because you don't care about memory, you look about effector responses. We're preventing severe disease with an old vaccine. The question is whether with the new vaccine will contain infection. We'll see with the Omicron vaccine that is arriving whether we'll be able to prevent infection. And I stop here. So that is with Omicron, we are making SARS-CoV-2 like a seasonal flu. In fact, we have an enormous number of infections with Omicron. In a month, we had only in Italy, about a quarter of the population was infected. Among vaccinated people, lethality about Omicron is 1 in 1,000, similar to seasonal flu, while among unvaccinated is 1 in 50, 1 in 100. So, and about 98% of people in intensive care unit or death are people over 50 years old. In Italy, only 7% of people over 50 are non-vaccinated. And they contribute to more than 70% of people in intensive care units, which is the clear evidence that vaccines do work very well in preventing disease. So this only certainty we have that anti-COVID vaccines are life-saving. Thank you. And this is about a possible, another virus which will arrive, because in the last 19 years, we had, this sequence of SARS-CoV-1, MERS-CoV-2, and all the situations that have generated the spillover from bat into intermediate guest and man are all there. So we may expect in the next decade a major spillover of a SARS coronavirus. So that's why when Antonio was saying people are going after it, a pan-coronavirus vaccine is the way to go, or pan-coronavirus antibodies. Thanks a lot.
Thank you, Sergio. Now, really, and sorry for the mistake before, I want to invite Professor Baldanti from San Mateo Hospital in Pavia, and his talk is entitled Diagnostic Development and Innovation. I take the opportunity to thank Fausto for his amazing work he performed during the first wave of pandemic, and for the excellent work he's doing now, still now, during all the pandemic phase. Thank you. Thank you, Fausto.
Thank you, Andrea. Thank you for the invitation. Can I have the first slide, please? Okay, so someone in the past said that the virus is a piece of bad news wrapped in protein. And actually it was the case. And the news came from a city, Wuhan, with a total population of 10 million inhabitants, the same as Lombardy. The same size, one single city, the same size of an Italian region. And the news was the coronavirus. And I don't know if you noticed, but we call the disease COVID-19 just for a single day. Well, the laser here. So the alert was issued on December 31.
Questo Covid a dicembre.
Well,
The translator.
okay. So the COVID was the date of the alert was 31 December of 2019. So for one day is COVID-19. And after 10 days, more or less, 9 of January, the sequence of this virus was released, and everybody could develop assays to face this new threat. One point is when a new virus arises, the first problem you have is how can I detect it? There is no assays, there is no way to detect a new virus. But the networking in this was really helpful because having the sequence in the internet allowed for us, for instance, our lab to develop some PCR technique and sequencing technique, order the reagents and having the lab ready in 10 days for a potential travelers coming in Italy. And I remind you that in that days, the problem was a distant problem, was far away in China. And the issue was, how can we detect a new virus coming from China? So all the airports were checked, were controlled, all the travelers were screened by thermoscanner and so on. And no cases were detected except two Chinese travelers that were admitted in Rome at the Istituto Lazzaro Spallanzani. And finally, this is a date. Please look at the weird sequence of numbers. 2002 at 8 p.m., so 20:00, we received the sample from a patient that was admitted in intensive care unit in a small hospital in a small town southeast to Milan, not in Milan, the big city, big connection, many people living there, but in a small town, distant from Milan. And the patient didn't travel to China, not had any contact with the Chinese travelers or people who traveled to China. But the next day, the contact tracing, you see the patient is here, February 20th, first case, hundreds of contacts positive in that small town, hundreds, 150, 160, 180, every day hundreds. So in that day, we were in front of the worst scenario one can possibly face. So a large outbreak, you don't know when it started and how it came there. And so you have to control that situation. Recording the symptoms of the positive cases, there was, you see, the trail of memory in patients, let's say, indicating mid-January as the initial starting point of the pandemic. Well, maybe not all of you know that in Lombardy, the first wave, we had two major outbreaks. One is in the Lodi area, the small town. The first patient was detected here, and southeast of Milan. Milan is here. And the second outbreak was in Bergamo, and the Bergamo outbreak was much worse on a clinical ground than the Lodi outbreak. So the Lodi area is 107 square kilometers and contains about 50,000 inhabitants. In those days, 1 out of 3 patients died. So we were in a desperate situation to find something to treat these patients. And as Antonio Lanzadecchi pointed out, we were digging up our knowledge and started a program for convalescent plasma. And where is the best place to find donors of convalescent plasma? So in the very middle of the first hotspot. And so we asked, these are the 11 municipalities that were first locked down 3 days later, 3 days following the initial detection case. And there are circles. So the outer circles are the number of blood donors in each of one of these municipalities. In the middle circle, the one that responded to the call, and the inner circle, the positive donors. And we were looking for plasma donors with high titer of neutralizing antibody to be used as treatment for patients. But meanwhile, we could first detect, have a picture of the spread of the virus in Lombardy, the first picture of the spread. And basically, we found that about 33% of people living in this area were affected. We were expecting much more, but we're only 23%, meaning that 75% were still susceptible. And so the spreading was not over following the lockdown. First indication. Second indication, the first wave was hitting more or less 10,000 individuals in these initial outbreaks. And collecting stored sera, we could detect 5 patients here in this place here that were positive for antibodies in February 12. And since we know that neutralizing antibody develop in 3 weeks, more or less, again, 15 January, the starting date for the infection in Lombardy. But how could it be possible that the virus can circulate undetected and infect 10,000 individuals? I remind you, we are in February. And during that time, there was a flu season ongoing. And nobody cares. Nobody at the time cared about people sneezing. The majority of these cases were either pouchy symptomatic or asymptomatic, and the virus could really spread for 1 month uncontrolled, unrecognized, and indeed inducing this situation. And the second question is, why not Milan? That was the obvious target in Lombardy. Why Codogno? There is nothing in Codogno. There is no artistical attraction, no natural attraction, no food attraction. So why Codogno? Well, these 11 municipalities here are embedded in one of the biggest logistics in Lombardy. And all these small villages are in the middle of the huge logistics. And while we were tracking travelers by plane, what it was moving by ground, train, trucks, and so on was not checked. Okay, by the way, people having had mild infection, they did not develop enough antibodies to be used in plasma treatment. Only the recovered patients admitted to the hospital had enough antibodies to be used in plasma treatment. And, sorry again. And at that time, with a mortality of 30%, plasma was really helpful in reducing mortality, short-term mortality, to 30% to 6.5%. So at that time, this approach worked. But as already Sergio Abrignani pointed out, not only antibody are important, but also T-cell response. So we did measure T-cell response in recovered people, and against all the different antigens of the virus, and you see that there are really high level of response, but also unexposed individuals do present in some cases some weak but existent response. And these are cross reactions to the human coronavirus that are usually related to common cold. There are 4. 2 are in the same subfamily of SARS-CoV-2. By the way, one of these, this one, is myself. At the beginning of this is one sample of mine taken 3 years before, and there was already a cross-reactivity. So maybe not all, not the 100% of people living in Lodi was affected because of sort of cross-protection by other mechanisms. Another important feature is that the maturation of the T-cell response is different from the humoral response. So weak infection, small number of antibodies. Big infection, big number of antibodies. T-cell response is working differently. There is no difference in mild versus severe response. So even mild response can create strong T-cell responses. And in most cases, these T-cell response are CD4. This is the first wave, okay? First wave that was fading off due to lockdown at the end of April, in the second part of April here, okay? Which variants were circulating in Lombardy during the first wave? There was a single variant, the Chinese variant. There was something different. Actually, Lombardy was simultaneously hit, but by 7 different variants in the first wave. 7 different variants. The Chinese original virus is this one, the A lineage, and was a minority of cases. So the second lineage, the first big lineage circulating in big numbers was the B lineages. This is the variants with no name. We are naming alpha, beta, delta, and so on, but the very first severe variants was this one, the no-name variants. So the variants with the mutation in the spike protein in D614G, and different 6 subvariants. So meaning again that region in Italy was hit simultaneously several times during that initial months of uncontrolled transmission. And most important, were these variants distributed equally? No. The Lodi outbreak less severe at this distribution of variants. The Bergamo outbreak with a mortality and infection rate much higher at a different distribution of variants. So variants were indeed impacting differently the two major outbreaks in Lombardy, the first wave. Then the first wave was over and the virus was thought to be clinically dead. And restrictions were lifted and people were starting again traveling and going vacation without any restriction. And many variants were indeed introduced again in Italy, okay? And now it's accepted. And this multiple introduction of variants was anticipating the second wave, like embers behind the ashes. And the second wave is this one. So the first wave was involving basically only Lombardy and was closed in 1 month, 2 months. The second wave was 10 times higher and was due to the spread during the summer of these variants. Okay, what happened to individuals that got infected and recovered? They must have some kind of immunity, maybe protection. How can we measure that? Putting together data from three different hospitals, from healthcare workers in 3 different hospitals, ending up in almost 10,000 individuals, we could see that in the second wave, only 2% of seropositive individuals got reinfected. And making all the calculation, the natural infection was protective in the same level of a vector vaccine, more or less, give or take, okay? But this was the time of previous variants, and then Alpha came along. And then also started the vaccination campaign. These are data on the 4,000 healthcare workers of our hospital, Policlinico San Matteo. And during the initial vaccination campaign, started at 27 December 20, also the Alpha variants came. And so vaccination and the spread of the variants were simultaneous. What was the protection? So the protection was high, as already pointed out. So you see that less than 1% of vaccinated individuals got infected with respect to the almost 6% of not yet vaccinated. And that makes up a 95% protection of Pfizer vaccine against the Alpha. But what was really interesting was this data here. So the one that got infected during the first wave and then got vaccinated, so had a triple exposure to the antigen, they were less susceptible. So only 0.5% got infected. No one with this with high level disease. Well, okay. So this previous infection, so exposed patient, then have an advantage? Yes. These are the total amount of antibody of healthcare workers having had an infection following first dose vaccine and second dose vaccine. You see that the maturation of response is high to the highest level and is maintained high. The naive, so unexposed individuals, the first dose with the spread of the antibody titers and then grouping at the highest level only following the second dose. And in the bottom panel, you have the neutralizing activity. And you see that even after 2 doses, it was evident that naive individuals, people that saw the spike antigens only twice in their life, had, well, a spread of response, neutralizing response quite high, from very high to very low. Also, the T-cell response follow the same, but the maturation is different. It is kind of delayed, and it is less adherent to the neutralizing activity. And what about variants? Again, this is the original Wuhan, this is the Bergamo strain, this is the alpha, beta, gamma, and delta. And the pattern is always reproduced. Individuals having had a previous experience with the virus and got vaccinated, they were able to mount and maintain high-level neutralizing activity. So what was said about protection and induced by multiple exposure was true also in this respect. Again, in that time, last summer 2021, California reported a high number of infections in their healthcare workers that all of them got vaccinated. And they were saying Delta is infecting the vaccinated individual as they didn't have any vaccination at all. Basically, this is the patient saying that the curve were paralleling the increase of the Delta circulation in population and increase infection in healthcare workers. We did replicate with our group of healthcare workers and we did not see the same. In fact, Delta was becoming predominant, but the number of infection in healthcare workers was coming down. The difference between California and Italy was that in California, all healthcare workers got vaccinated, but general population was delayed in vaccination. In Italy, healthcare workers get all vaccinated, but also the campaign was parallel. So the protection was much higher in our population with respect to California. Omicron. Omicron indeed is able to overcome the barrier because infection is possible, as already pointed out. And is possible also sometimes in boosted individuals. Not so easy, but is possible. What is important to notice, this curve here, is the binding of the Omicron to the, so the RDV to the, of the Omicron to the receptor. And the binding of the Omicron to receptor is much lower than all the other variants. And that make point in a direction for the observed less high clinical impact of these variants. Boostering. Boostering is helpful. This is one paper we collaborated with in a multi-center group, and this is a hybrid boostering with mRNA on top of proteic vaccine, and indeed, in this case, you see that Omicron is recovering, the effect against Omicron is recovered by the boosting. What is interesting is this panel here. So all the convalescent that got vaccinated has the same level, again confirming that situation. So maybe in this world, and this is our preliminary data in healthcare workers, you see first dose, second dose, these are total antibodies. After 6 months, antibodies fall, third dose, antibodies get up again. Neutralizing activity, first dose, second dose, 6 months is decreasing, after the boosting is recovered, and the same, less evident, but the T-cell immunity. And again, against the Omicron. You see, Omicron is not responding to 2 doses of Pfizer vaccine, but after 3 doses, at least a partial response in terms of antibody, neutralizing antibody is recovered. Okay, so what is interesting now, would be interesting now to follow, what is? Well, what happens? We saw that there is an advantage of who got an infection, okay, and then got vaccinated, high level response. But now, who got infected and on top of that got the infection by Omicron? Maybe that's another situation to be studied. Okay, just to conclude, the technology that was really helping us in this case at the 2020, we had nothing, no technology at all to confront this. Now we have technologies to measure antibodies, to measure T-cell response, to measure inflammation, to check carefully the variants, okay? All this technology, but also this was the very first event where application apps could help in finding and selecting patients. This was one app developed very early in April by Regione Lombardia, helping a physician to detecting potential positive patient by symptoms. Now we have more than 30 different apps helping in detection and tracking the contacts. This is the Italian one, Immuni, not much used because of many reasons, but this is something that I wanted to bring up because in the future telemedicine already told about could be really one breaking point. And also technology, non-invasive technology. Another app measuring the vibration in voice from positive COVID versus healthy people, positive COVID patient versus recovered, or recovered versus healthy, that can really tell you something, and without any sampling, at least screen individuals. There are many techniques that are evolving in this. You see this diagram. In blue are the healthy individuals, and in red, COVID, the voice alteration in COVID-19 patient. And you see there are some spots that can be used to at least have an initial stratification of the problem. And finally, I want to thank the group, and in particular, all the young students that were helping us in confronting this pandemic. Thank you for it.
Thank you, Fausto, and now it's been my pleasure to introduce Rino. I was happy that Antonio spoke before me. I learned immunology from Antonio and vaccinology from Rino, so for me today is a big day. So Rino will update us on, sorry about that, on new approaches to infectious disease control. Rino doesn't need too much introduction. He's considered one of the best vaccinologists worldwide. So Rino, please.
Well, thank you, Sergio. Hi to everybody. It's a pleasure to be here to talk to you a little bit about the what kind of approach we can have to infectious diseases, emergency infections, things like that. So when I talk about infectious diseases, I like to start with the slide. With this slide. This is an ambitious slide because it tries to summarize human evolution in one slide. And if you start on the left, you see the beginning of our planet. Then you go 12 million years ago, when our planet was populated only by monkeys. And then 5-7 million years ago, the first one diverged and started the long million years evolution that brought to our species. And then going toward the right part of the slide, you see like 100,000 years ago, somehow the first humans got out of Africa and started to go to Europe, then Asia, America, and that's what we have today, the society. Now, the real reason to show this slide is this red line that you see, this red line that basically goes across the entire slide. That line is the life expectancy of our species for 3-4 million years. For 3 million years, our predecessors at the life expectancy of 25, 30 years. And then at some point, 1750, the life expectancy started to go up and was a kind of straight line going up, up, up. The life expectancy went to more or less 45, 50 years in 1900, a century ago. And then since 1900, that's increased, at least in the Western world, up to 88, 85 years. And it's amazing to see that in the millions of year evolution, just in the last few hundred years, and just in the last century, we gained 35 years of life expectancy. And during the last 2 centuries, we gained 55 years. And the question is, why did it happen? What's the reason? Why we live so long today? And obviously there are so many reasons, but one way to answer the question of why we live longer is basically to go to the records of a century ago, 1900, and ask the question, in 1900, when people lived less than 50 years, what was the cause of mortality? And you can do that in many countries. The one I'm going to show you is the United States, because there is a very complete record of that period. And if you look at that, the next slide, you see 2 things. 1900, the cause of mortality was caused by infectious diseases or by any other thing. Infectious diseases will be in yellow. And here what you see, 1900, 57% of the mortality was caused by infectious disease. Then, 1925, the mortality from infectious disease was much less than 40%, 1950 much less, 2000 less than 5%. Remarkably, while the mortality from infectious diseases went down, life expectancy went up. So the conquest of infectious diseases has been one of the major reasons why life expectancy has gone from basically less than 25 years to 80, 85 years. And obviously, which were the diseases that killed so many people? I mean, 1900, 1.5 newborns will never reach 5 years of age. And obviously, some diseases like diphtheria, that, there are many, but diphtheria, tetanus, pertussis, smallpox. But diphtheria I want to mention because in 1900 in Germany, diphtheria caused 50,000 people, 50,000 deaths. In 1925, the United States caused 15,000 deaths. And today it's completely gone. Nobody remembers diphtheria because it's been completely conquered by easy vaccination. So when I look at this slide, I basically think that the conquest of infectious diseases is probably one of the most important milestones of our civilization. And how did we conquer infectious diseases? Well, basically 3 things: antibiotics, vaccines, and hygiene. Hygiene is very important. We know it's extremely important. And today, in the case of pandemic, we wear masks, we social distancing, we wash our hands, we do things, because hygiene is extremely important. And we know it's effective and works. However, in some cases, there are limitations, because especially if you go to low-income countries, you cannot say, tomorrow your hygiene will be perfect. It takes 30, 50 years, sometimes takes longer. The other thing which have been helping us to conquer infectious disease have been antibiotics. Antibiotics are fundamental. Since 1940s, when I started to use them, they basically saved so many lives. But they have a problem. When you use an antibiotic, basically immediately you get resistance. A few years later, your antibiotic is obsolete. If you have another one, it's not a problem. You move to the other one and you move on. But then you get resistant to that one. And if you have another one, it's not a problem. You use another one, and so on. But then you may end up where we end up today. We don't have new antibiotics. Our science is not able to find them. And so now we are basically in a huge problem because we are running out of antibiotics. And the antibiotic resistance is one of the big problems of we have today. It's very likely that's going to be one of the next pandemics of the world. Coming slowly, but extremely important. And then we have vaccines. Vaccines basically are, they do work. And the beauty of vaccines is once you find a vaccine for a disease, usually you don't get resistance. So basically, vaccines have been able to manage and conquer and eliminate a lot of infectious diseases that used to kill children and infants, so far. So basically, these are the three pillars that have been used so far. And thanks to these three pillars, basically, infant mortality has disappeared. Our life expectancy is long. And basically, we've been able to conquer most of the infectious diseases that used to kill millions and millions of children. A huge, huge achievement. So the question is, are we done with infectious diseases? And obviously, it's a rhetorical question today. But because the fight for infectious diseases really continues. Yes, we have conquered most of the disease, the infectious diseases that used to kill the children, but there are a lot of new challenges coming up. Antimicrobial resistance, I mentioned it, is extremely important, completely underevaluated. And then all the other emerging infectious diseases we made, they appeared since 1980, HIV, SARS-CoV-1 in 2002, influenza pandemic in 2009, MERS, Ebola, Zika, and today SARS-CoV-2. All these infectious diseases are basically found not only us, but the entire world completely unprepared. And the question is, if we have been so successful in conquering infectious disease of the infants, why are we not successful in mitigating or treating or basically controlling the emerging infections? Do we have the technologies? And I'll show you that we do have the technologies. What we have, we don't have the investment, the infrastructures, and the things which are necessary to do that. What about the technologies? Well, 20 years ago, we used to make a viral vaccine. We needed the virus. We needed to grow, kill, and do a lot of things. But then, recently, we don't need that anymore. Approximately 25 years ago now, we were the first one, basically, to use genomics to discover vaccines, which means that you don't need to have a virus and bacteria or everything. You just need a genome. And then, 10, 15 years ago, the synthetic biology came in. So today, when in January 2020, the SARS, the COVID virus basically was discovered, was you didn't need to ship the virus. All you needed was basically get the sequence that was put on the internet on January 10 by the Chinese Center for Disease Control. And the sequence basically teleported through the internet. We used that by more than 300 groups worldwide to make a synthetic gene. And then they used the synthetic gene to make three types of vaccines. One, which was the fastest, one based completely synthetic, made by RNA vaccines. That was so fast, in 2 months was in clinical trials. The others used the synthetic gene basically to splice the gene into a viral vector, and then they grew the vector, like mostly adenovirus, and 3 months later were in clinical trials. Others used the same synthetic gene basically to engineer a mammalian cell, yeast cell, or tobacco cell to make a recombinant protein. And then the protein had to, the recombinant vector had to be grown, the protein purified, combined with an adjuvant, and then you make a vaccine that's gone to the trial. These are the vaccines that have been developed. They all came from the analysis of the genome. They're all synthetic, without having ever seen the virus. So I believe in this period we transition what I call from analog vaccines to digital vaccines. What's the difference? Well, before this pandemic, basically before reverse vaccinology, to make a vaccine, you need a virus or a parasite or a bacterium, and then you need to grow it, and then you basically either kill it and inject, or attenuate and inject, or purify some recombinant proteins and inject. But you need a fermenter. With the digital vaccines, well, you don't need any of these things. You need the sequence, the internet, a robot that will make a synthetic gene, and then you inject the RNA. But you do not inject the vaccine. You inject the code to make a vaccine. So essentially, we've gone into the digital era of vaccination. So today, we do have technologies to make vaccines very rapidly. And basically, you start with the sequence. But you also have the possibility to basically sequence globally all the viruses worldwide and then prepare for vaccines for things that may come in the future. So I think the technology is there. However, as Sergio said before, we have been able to make vaccines in 10 months. Was just the technology that allowed to do that? No, and Sergio mentioned that before. What happened was that there's been huge intervention from the public sector. And Sergio explained this very well. Basically, before, in order to make a vaccine, first you do discovery, doesn't cost that much. Once you've done discovery, if it is successful, you move into phase 1, and this costs a little bit more. And then if that works, you move into phase 2, this costs a little bit more. And if that's successful, you start to build a manufacturing plant, you need to do a phase 3, and all these things cost more or less $1 billion, sometimes more. So companies will never do step 1, step 2, step 3, and so forth. What happened at this time is basically the government, most of the American government, they wouldn't wait. So they came to companies that told us, well, I don't want you to do these things sequentially. And they said, they had $13.5 billion from the Warp Speed plan. They came to companies, they said, here's $1 billion from companies, other companies said, here's $2 billion. I want you to do the following, do the things in parallel. I know discovery can take a lot, but as soon as you get the first thing you think is going to work, don't wait to discover at the end. I mean, immediately go to phase 1. And I know phase 1 study is going to last 18 months. But as soon as you have a safety and the first thing on immunogenicity, you go to phase 2. And phase 2 is going to sometimes last 2.5, 3 years. Forget it. As soon as you have the first thing, go to phase 3 and move on. And so basically that's what was done. And thanks to that, basically the development basically went from 10 years or sometimes longer to 10 months. The amazing thing is that, and this is important because most of the people do not understand it, is that this time has been possible by taking a financial risk, which has been taken by the public sector, but without taking any risk on efficacy and safety. Because all the steps were done, they were done in parallel and not sequential. So I think we learned 2 things. We learned we have the technology, and we learned that we can move fast, provided there is a right investment. And so I think we are well equipped for future pandemics. And now you see for the Omicron thing, 2 months after the first time that Omicron was described, clinical trials with RNA vaccines already started. So these things is replicating. And so that's what I wanted to say about vaccines. Then the other thing which have been discovered in this pandemic has been the importance of human monoclonal antibodies for infectious disease. And here I think a lot of the the pioneer, I was lucky because in 2002, when SARS-CoV-1 appeared, I had the fortune to collaborate with Antonio when he did the first cloning of the human B cell for SARS-CoV-1. And as Antonio said, infectious diseases, so human monoclonal antibodies have been licensed for many diseases, from cancer, cardiovascular diseases, but really for infectious diseases have been lagging behind. And it's really thanks to Antonio, I would say, that they've become important and started to work. The reason why I've been lagging behind is because 10, 15 years ago, it was very difficult to make human monoclonal antibodies will be potent. But between 1990 and the case of HIV, for instance, we've gone from very lousy antibodies to antibodies that are 1,000-fold better than used to have. And so basically, when the COVID pandemic arrived, we were more or less at the peak of the possibility of making really, we had the technology to make very good antibodies at the right time. And I really was impressed by the collaboration with Antonio back in 2004-05. And I always thought that human monoclonal antibodies would be part of the future for infectious diseases. But I never had the possibility to do that until 4 or 5 years ago, when basically I got a grant from the European Union, for European Research Council, basically to make human monoclonal antibodies for bacteria resistant to antibiotics. And the reason I wanted to do that is because they are good tools for therapy and prevention, but also can be, if you do work well with them, you can really accelerate vaccine development. In fact, if you have a good antibody, basically, you can shorten also the vaccine development by several years. So with that in mind, I started a project and hired people to do human monoclonal antibodies to bacterial resistant to antibiotics when 2020 the SARS-CoV-2 arrived. And then it was a kind of, we had to do it. We had to move into making human monoclonal antibodies for COVID. So basically we started, and we could take blood from people recovering from disease from the Istituto Spallanzani, University of Siena, and we basically started to clone, following more or less the pattern initially pioneered by Antonio, and today is basically used by many groups worldwide. So we isolated more than 4,000 different cells, B cells specific for the for SARS-CoV-2, and we had in mind from the very beginning that we wanted to make very potent antibodies. The reason is that the antibodies of the first generation, basically, they have low potency, so they are required large quantities, which means they are expensive, and they can only be given by administration, intravenous administration in hospital. What we wanted to do is, from the very beginning, really second generation antibodies, which were high potency, so the small quantities are needed, and we really wanted to develop something that will be also useful for low-income countries, so will be affordable because you need small quantities, and you could deliver by intramuscular immunization, so you don't need to go to the hospital, things like that. So we worked on that. We looked for the most potent antibodies, which are very rare. You see, out of 400, we found only 3 which were potent at that level. We developed them, we published them, and then we wanted to do the industrialization of this. So basically, you spend time developing the antibodies, and then at some point you need to industrialize them. Now, if you are in a company, an organized company, all these things are automatic. People know how to do it. But if you are, like we were, a laboratory, semi-academic laboratory trying to develop these things, you don't have the logistics. So you have to find who's going to make the cell line, who's going to make the cell bank, who's going to make the fermentation, purification, how we're going to interact with regulatory agents. So you have to invent all these kind of things. And we did it. It was a kind of heroic, but took longer than it would take to if you are in a company. And we went through several regulatory processes, which if you have a well-oiled organization, obviously you don't have. So eventually we made it. We did the phase 1 clinical trials with 50, 100 milligrams and 400, which was much lower than most of the other antibodies that have been developed in the meantime. We were very surprised to see that we're delivering them intramuscularly, and with 50, 100, and 400 milligrams, we basically, in a few hours, we're getting level of antibodies in the blood, which were much higher than the highest level you can induce by vaccination, even when you vaccinate people already infected and vaccinated. So the scientific data were beautiful. We wanted to move into phase 2, 3. We started doing that. But again, even here we took, we basically was a double-blind placebo control, and we wanted to enroll 800 people, but we managed so far to enroll only 300 because it was very difficult to enroll these people in Italy. And then, while all this happening, the virus was not waiting for us. And so basically, we got the first variant, the second variant, the third variant, and so on. And basically, the antibody maintained well against alpha, beta, gamma, delta. So I was really well, behaved extremely well. It was the most potent that been in the clinic against all these variants. But then Omicron arrived, and Omicron basically not only reduced the potency of our antibody, but basically reduced the potency of all monoclonal, 85% of all monoclonal antibodies. All the ones that have been approved have been basically lost their potency, with the exception of the one that Antonio mentioned, and which is the only one that's really survived this thing. So the lesson from that is that you can do it, but you need to be better organized. You need to have the infrastructure ready and the supply chain ready before, because if you try to set, it's like if you try to build your boat before, while you sail, doesn't really work. And so basically, final consideration is basically we are all vulnerable to emerging infection. They kill millions of people and cause massive economic losses, so we know that. But we need to invest really to be prepared. We need to have infrastructure, the knowledge, the science before things happen. Because if you react, it's too late. And obviously, we need to make vaccines not only for the pathogens that we know, but also for the ones that will come. So we need to make a huge investment globally to do it. And obviously, what the Omicron story tells us that research should never stop at the first thing. Research needs to continuously develop new things and try to be ahead of the virus, if you like. And obviously, we need new vaccines and monoclonals, and new vaccines have been developed against the Omicron and other variants, and against and thirdly, we cannot stand still. Out there, we know there are at least 120 known viruses with an increased potential for human-to-human transmission. 26 viral families are known to infect humans. Most of the bacteria become resistant to antibiotics. So I think final message is we have the technologies, we know how to do it. We need huge, well-coordinated global investment, basically to make sure that we are better prepared in the future. Thank you.
So my question in the end, so we finish so it is now my pleasure to introduce Giuseppe Ippolito from the Italian Ministry of Health, where he's Director of Research, will update us. He's connected from Rome, we couldn't make here. Innovative model of management for pandemic control. So thank you, Beppe, for joining us. You have 20 minutes.
Thanks for this kind invitation, and I will share with you my screen and try to summarize, continuing on the same line that Rino Rappuoli started now, how we can try to have an innovative approach to the pandemic control in terms of public health and on research. In this context, Italy was the first Western country to deal with the problem of SARS-CoV-2. Just 1 year ago, 2 Chinese tourists arrived in Rome, and the same day, the Minister of Health, Roberto Speranza, established that air traffic embargo. Air traffic embargo was criticized by other countries, but was the same approach used by other countries in a few days. No one was considering that the virus was already circulating, as Fausto Baldanti showed. The virus was already circulating in the country, and since 21st of February, Italy discovered the official case, and so the government established a very hard and strong lockdown. Gaps in preparedness, our long history. I spent most of my life in preparedness for emerging infection. This slide is no anterior slide. This was in 2004, a slide on the European Observatory for Preparedness, and 15 years ago was reported that Europe don't have public health capacity for response to the emergency, lack of documented research on the mechanism of decision making, not just research, the lack of the analysis in the field, lack of the international comparison, and decentralization in the decision, with extensive pluralities in health policy making in different countries. This was considering 15 years ago the major limitation in the response to a pandemic and the weakness of public health infrastructure. When we said public health infrastructure, we include communication. Communication was really one of the critical aspects. And also before the appearance of SARS-CoV-2 in the Global Health Security Index in 2019, was reported that no single country or single health system worldwide was fully prepared for catastrophic biological event. But it was very difficult that nothing will occur. We have a long history and several drills that try to suggest to the politicians and to the public health official to work. So this outbreak is not a surprise. But when the COVID-19 appeared, there was no time to rest, and considering accomplishment in the past for other disease. This sentence is for Charles Darwin, is not mine, but we must try to survive. And what is important is all the health systems were overwhelmed. Rapid policy changes were requested to try to manage the patients. And this request a rearrangement of emergency plan in terms of preparedness and response. Italy was the first to deal with the problem. So early detection, according to the rapidly developed diagnostic, as Fausto Baldanti told us, for us, we tried to put in place rapid response. And we were example for rapid response in other contexts and for other countries. First response was doubling the number of intensive care unit beds and increasing, doubling the ratio of beds per 100,000 inhabitants, and increasing by 50% semi-intensive care with full equipped beds for cardio and respiratory monitoring. But unfortunately, like Michael Oppenheimer in his wonderful book of decision-making report, that to make decision rapidly sometimes is difficult since we don't have data. And experts don't have the same position, no textbook experience to guide the response. The risks evolve across the time, and the rapid process for scientific approach in the midst of crisis is often difficult. When SARS-CoV-2 appeared, United Nations agency were ready to commemorate the 40th anniversary of smallpox eradication, and this was the stamp. Unfortunately, this was not good luck for the world. In the 11 and 12 of February of 2020, WHO convened the first meeting for research of collaboration on disease preparedness. The virus was already among us, and the list of priority continued to be on the top of call for research: transmissibility, severity, susceptibility, and the impact of intervention. 2 years later, most of the research needed to be addressed are the same. Knowledge gaps continue, such as research effort. In the 2 years of scientific research, first recommendation 2 years ago in a wonderful editorial published in Science was against pandemic research exceptionalism. And this unfortunately was one of the crises of the time. The Ministry of Health launched a special call for research on COVID with the special fast-track procedures for 7 million euro involving for all the researchers in all disciplines, not closed, from diagnosis and treatment to the communication society. The call was launched according to the World Health Organization research agenda, and 91 applications were reviewed and 10 approved in less than 3 months. But this funding of research was critical to accelerate innovative research, to help the Ministry of Health, Ministry of Research, to identify areas of excellence and areas that need to be taken up, evaluate the impact of founded researchers in the past and plan a new activity, to map the scientific capability available in the country and recognize the maturity of research toward development. So this special call was a success for the country, contributing with the scientific activity with more 2,500 papers just in research institute affiliated to the Ministry of Health. Why this is really critical for the country? Yesterday, since I apologize, but I prepared the slides just yesterday, in the PubMed were reported 200,000 papers. 8.90% are Italian. This is a very large success for the country. If you consider that 1 in 8 were paid directly by the Ministry of Health. But not all researchers are the same. We need to invest in diagnostic, in patient care, in basic biomedical research, in the human and animal interface, in prototype, in industrial, in manufacturing research, with the goal of local, national, international positioning of research, with the single or multi-system approach, including the aspects of security for biocontainment. What are the benefits and potential benefits of funded research, not only in Italy, but also by EU, since Italy received a lot of grant by European Union? Direct benefit for patients or indirect benefit for patients? Benefit for the community in terms of tracing and reducing case fatality rate? Benefit for the advancement of science? Benefit to try to control the social alarm, and in terms of construction of facility and research and infrastructure. When the Ministry of Health decided to follow this approach, this strategic map or this topic map was followed. Not all the circles were successful, and not all the systems received at least one call or published at least one paper in the area. But this map was very important, since the landscape of research with this scientific approach was published under the umbrella of WHO 3 months ago. And the reporting that funded publication represent 1/3 of total publication with the founding acknowledgement analysis. And this was the China was the first in producing funded research, funded not in terms of amount of money, but in terms of published paper under the funded research. And the funding ratio was 69%. USA, 27%, but with a funding ratio of 31%. Italy ranked 76%, and the funding ratio was exactly the same. So this study that was supported by WHO to evaluate the landscape of research with this uncommon approach identified also that the collaboration network, as quoted in the papers, China funded 23% of all the networks, and China was involved in 20% of all the networks. To have an effective research, we must invest. And this was a paper that I published quite 20 years ago, investing in the basic and translational research with the complementarity and the multidisciplinarity. Investing in research of public health in terms of coordination and standardization of policy, in terms of diagnostic for our common protocol, reagents, and well-trained personnel, and last but not least, in clinical research and in infection control. 1 year ago, Bill Gates recommended to start a new program for the future pandemics. But future pandemics must be considered a response based on the complex adaptive system that are distinct from complicated systems. This seems very difficult, but the same approach of the earthquakes must be used to have innovation in care delivery through appropriate research. And we need research on healthcare and research in disease model. This is an area not covered until now in Western countries. Few months ago, in the Rome Declaration in May this year, the President of the European Commission and Prime Minister Draghi, among the key points, reported that was a priority for Europe to support and enhance existing multilateral health architecture, with the leverage on the synergy for data sharing and capacity building, and a research that must be streamlined, sustainable, predictable, with the system for long-term financing as surge capacity. Few days ago, just 5 days ago, this wonderful paper was published in the British Medical Journal to take the politics of intersectional action for healthy people and the planet. But the 3E, that is new theory, is considering the distribution of exercise of the power to promote intersectional action, to define associated political dynamics. Why this new approach is critical now and is important? Since the pandemic is requesting strongest resilience in the planification, the plan of emergency of preparedness and response. So we needed to create national reference center in the field of high impact infectious disease, increase laboratory capacity, in standardized protocol and the definition, in research activity, in an integrated One Health system, and in capacity for outbreak control. The National Reference Center is one of the key action that Western country must put in the National Health Protection Plan for, and the reference center should be ultimately responsible for surge capacity and mobilization. In the plan for response that now is part of Science 20, with some European colleagues, we wrote this, published in Nature and International Journal Infectious Disease to support the European decision in investing in preparedness, since it's more cost effective than investing in response, in successful management of preparedness through scientific collaboration with the participation of all member states of G20. This is now a basic part of G20 and will be the standard assumption for the next G20 under the German presidency. The pandemic highlighted the interdependency of people with the mutual vulnerability and the concentrate of warning system considering the risk of zoonosis. Now we are trying to capitalize previous experience in the National Resilience Recovery Plan and in the National Plan for Complementary Investments. And in this strategy, thanks to the strong collaboration between the ministers of health, the Minister of University and Research, and the Minister of Economic Development, several actions have been established. The three ministers have a technology transfer program, and the two ministers, Minister of Health and the Minister of University of Research, are investing in national research platform. For Ministry of Health, there is plan for an anti-pandemic app for research developed until the pilot production of vaccine and the monoclonal antibodies, as reported by Rino Rappoli, to reinvent and recreate the long-lasting history and the capability that Italy lose in terms of vaccine development in the recent year, a specific plan for biotechnology, bioinformatics, and pharma development, a national plan for response to influenza, including also economic investment for research that can be devolved to the regions named pan flu, a special program for advanced diagnostic and research networks and biocontainment facility paid directly by the Ministry of Health. And the Ministry of Research do a parallel system with the National Center for Biopharma RNA, with a special project for research on emerging pathogens and antimicrobial resistance, and with very rich call for innovative infrastructure and the new research laboratories. The Ministry of Economic Development through the Enea Biotech, is now investing in production of new drugs and vaccine. This is the model. It's the agreement between Ministry of Health and Ministry of Research has been signed just 3 days ago for a common approach for hub-and-spoke management of research in the line of science. And this is just an example, it's not a real case, based on the level of skill of the center, level of capability to identify hub and to identify high level of expertise and low level of expertise center, considering a limitation due to the law of involvement of all the Italian regions. So like 40 years ago with the history of AIDS, we must continue to work in 3 main areas of experience and investigation, the model of cooperation to design, build, and staff for people working in this area, with investigation for long duration data gathering. We have to invest now for the next 10 years, an investment that will stop with the end of the grant for projects, which is not useful for the country, and with operativity. Operation is crucial for with involvement of scientific and the human context. Research activity that we plan to promote is the understanding of the role of pathogens, pathogenetic and virologic approach, development of testing of therapeutics and vaccine, modeling capabilities, and multidisciplinary research covering clinical, epidemiological, diagnostic, and translational issues. To have this, we need also network for clinical trial and for other clinical studies through prearranged, ready-to-apply framework with the possibility to implementation as new outbreak start. Does it mean that we must have inter-epidemic mode and epidemic mode for the activity? Must be coordinated among public research agencies. This will be the goal, and I hope that for our future, that the best preparation, as reported by William Osler, for tomorrow is to do today work that works superbly well for the future. Thank you.
Thank you, Becca, for the complete and thorough presentation. So we move to the next speaker, who is Davide Manca from the Polytechnic of Milan, who's speaking about innovation and digital models. You have 20 minutes. Thank you.
Okay. Good afternoon. Just an outline of the presentation. You will hear a number of times models, just for the sake of understanding the past, identifying the present trend, and anticipating, forecasting, and predicting the future. So this will my main topic. Just a preamble. I'm a chemical engineer, so you would ask me what do you have? If you have anything about pandemic and so on, but just the very end of February 2020, as was just reported before, on the 21st of February, the first official case of SARS-CoV-2 was officially identified in Codogno, in a Lombardy region, in the north of Italy, the biggest, most crowded region of Italy, more than 10 million of people. And I received a phone call from the head of resuscitation department medical doctor Dario Caldiroli, a friend of mine. We were working on a completely different topic, the control of anesthesia, automated control of anesthesia in terms of anesthetic, analgesic. And I received this phone call, and I thought he was joking because he asked me, Dave, listen, with the help of your mathematical models, could you forecast the number of new cases of interstitial pneumonia and the load on the ICU? And I was just puzzled. And I said, Dario, I know nothing but the big pressure in the first days. There was what we have learned as the exponential growth of this event. And so, first of all, let us see how things go. We are used to see these diagrams because these are the summary and they are a representation, the dynamic, time-dependent representation of the first wave, second, third, fourth, fifth, the present fifth wave of the different outbreaks of this pandemic, COVID-19. In terms of ICU and in terms of hospitalizations, both in Italy and in Lombardy, the two curves. And okay, but we can also see, also in terms of total cases and fatalities, but also we can start understanding the behavior, comparing different waves, the first, second, and third, and so on, as a function of time, but also looking at different diagrams. For instance, this is no more in the time domain, but we call it the phase domain. We have two different variables. On the x-axis, we have the total cases over 100,000 people estimated on a 3 weeks time interval, longer period. And on the y-axis, the fatalities with the same number of people and over a 7-day term. And as you can see, we have different regions, Calabria, Sardinia, Lombardy, Emilia-Romagna, and so on, the different regions of Italy. And you see these, the dot means the last day, and this ribbon is long 7 days. So we can see how the system is behaving and as far the distance from the origin. The origin would mean no cases, no fatalities. The ideal situation when the outbreaks ends, the pandemic is out of scope, hopefully. So we can compare different regions and see different critical areas, the green, the pink, the red, the most exposed, high pressure. And this was a photo, let's say a snapshot of the 28th of January, just before traveling here to Dubai. And here, another diagram in terms of hospitalization and fatalities. And you can see that even we can move on a negative number when the number of hospitalization are decreasing respect to the previous situation. So a very good situation because the pressure on hospital is deflating. And again, we have some outliers. This is Valdaosa, it's a very small region, and the smaller the regions, the higher the volatility and fluctuations. But then we can go to the movie. We can okay, just before starting, we can put we can add also another dimension. I mean, we have on one axis the total positives, the hospitalized, and on this axis the fatalities. So the higher the stakes, the heavy the number of deaths. And on this wall, we can see the 2D projection, and we have number of different regions, not all the regions in Italy. And we will start from the first day of October last year. We were starting with the 4th, and then we will see the 5th pandemic. Okay, you can move, you can start. And initially, the situation was very good because the nearer to the origin, the outer scope of the pandemic, and then you can see that Friuli in the north of Italy was increasing so much. And so and they are moving in this red region, which is not good at all because we have an increase of the hospitalizations. And the green one would be the good one. Lombardy at that time was in this situation, but then, and we see here on January, this big increase. And the farther from the giant diamond, the worse. So you can see dynamically by means of a kind of movie how the system is behaving, and these numbers are very high, typical of the Omicron variant, because in the previous waves, this axis was much more shorter. Okay, we can go back, thank you, to the presentation. So this is just looking at the past. So learning from the past, okay, thank you. And so understanding the past allows predicting the future and also seeing the early warning. Because, for instance, when these ribbons, these dots move away from the origin, means that something is happening. So you can anticipate and measure this. So interpreting the present, there are two typical curve trends of the pandemic in terms of the big, evident, real values. In terms of, for instance, of ICU, in intensive care unit beds, hospitalized patients, and new cases. This is a kind of bell-shaped curve that is typical of different ways. The other curve is this one, which is the cumulative curve in terms of fatalities and total infected people during a wave or the whole pandemic. So can we model these? Can we describe mathematically these curves, trying to understand better how and where we are? The answer is yes. And you can see here, for instance, during the first pandemic, how the blue circles are the real data in terms of ICU in Lombardy and the total hospitalized people in Lombardy and in Italy. And the different lines, the different continuous or dashed lines show how the different models that I am going to describe allow to follow rather well this data. And also, here it was the last day when we worked and we published this paper, and we can also forecast what is going to happen in the future. This is very important because it allows us also to predict, to anticipate the future. So here, the same, these data are almost incredible from a chemical engineering point of view, because when you go to industrial sites, industrial plants, these variables, the similar variables, are very more fluctuating. They are rather smooth. The first time we were very impressed, but these are official data, Italian data, so they were not at any level biased or filtered by any government. This is very good. And you see that there is a very good overposition of the model, the dashed red line, that perfectly overimposes on the real data. In this case of fatalities and also in terms of total cases. Very good agreement. So using these models allows us to understand, anticipate, forecast, quantify, not only from a qualitative point of view, but also from a quantitative point of view. And this helped a lot the heads of a number of resuscitation works in Lombardy and in Italy, Milan, Lodi, Cremona, Parma, Udine, Perugia, who were, let's say, supported by our models just to, for instance, to allocate usually and mainly in the first wave that was the most with the highest impact, unexpected impact, the number of beds in the ICU. Just for the sake of an example, in a Lodi there were only 6 ICU beds before, and then they were able to increase the number of 2, 3, 4 times beyond 24, 26 patients, using also very non-standard areas just for the sake of accepting the high number of people who deserved ICU treatment. And so we are able, for instance, to answer this question, the doubling time. What is the time before I double my phenomenon? I have to double from 6 to 12 beds, from 12 to 24, and hopefully, okay, the pandemic reached the limit for that hospital, and then other resources had to be allocated. And then we go for linear system because we have also a linear trend, bell-shaped, increase decreasing, the rate of inflation and deflation of the system, the halfway time, also psychologically, you know that you are at the halfway of your phenomenon. The time delays between new cases, hospitalization, ICU, and eventually, if any, fatality, and also identify the so-called top, peak, plateaus, the maxima and the inflection points, and also go through given threshold. So that curve can be described, I will not go into much detail, but by these models, exponential, the Gompertz, very effective, was devised for different applications, but similar for insurance purposes in the 19th century. The exponentially modified Gaussian curve, bell-shaped curve, the inverse Gompertz up to the, hopefully, the asymptotic trend. And so these are the models. You see that they are rather simple. We have just a reduced number of parameters, A and B, or A, B, and C, only 3 parameters. You have to solve this model, this problem by means of a nonlinear regression algorithm. You are trying to minimize the distance between the real data, the experimental data, and your model. And by doing so, you find these parameters, adaptive parameters that allow you to use the model now, from now on, to not only interpret the present situation, but also to forecast, to predict the future. That is, from my point of view, the most important point. So this allows you, for instance, to allocate material resources in terms of ICU beds, COVID wards, breathing masks, oxygen supply lines, and the like, and also the most stringent situation, which is human resources, medical doctors and nurses, and also understanding, anticipating when you will be able to return to elective medicine or also schedule for surgeries. And then you see here, this was the first pandemic wave, and then you see that that was the present situation, and we were able to forecast with a matter of few days, depending on the models, that after almost 3-4 weeks, the number of ICU patients would fall below the 10% of the maximum value reached. And this would give rise to a new, for instance, return to elective medicine. The same also in terms of death. This is more a question about journalists' information, but also for decision makers, also to politicians, also to make decisions and get a better idea. So we can use these models for short-term, medium-term, and long-term predictions. Let us see how go and move from short and medium-term to long-term predictions. There is another family of models which is called compartmental models in epidemiology. These models were devised by Kermack McKendry almost 1 century ago. They are based on compartments, for instance, the susceptible compartment, the people who have not yet suffered from the specific virus, the infected ones, the recovered one, and the death one. And these are based on rather simplified and strict, sometimes I would say stiff hypothesis that, however, can be relaxed, and we will show how. You see here just the last slide with formulas, but from my point of view, these formulas are, this is an ODE, ordinary differential equation system. It is rather simple, only 4 differential equations, very simple in the time domain. And this is based on the balances between the different compartments. But you see that these beta, gamma, delta, which are not the variants, are only the coefficients, they can also be set as a function of time, and they, for instance, depend on the lockdown decision made by the minister, by the decision makers, they play a significant role. These models can be used, again, to understand what might happen. Let us see. You see here, these, again, the blue circles are the model, the red circles are the experimental values, infected, recovered, fatalities. And you see here that, for instance, by means of modifying the lockdown time, we were able to follow very well the previous term. Now you can use this model for what-if scenarios. For instance, looking at what is the role of the infection rate. For sure, I would say from one point of view that you are not able to make a, let's say, to have an impact on the infection rate, but you can see different variants, but you can also postpone or reduce the importance of the infection rate by means of increasing the lockdown or the distance measures. And so these are very good system because you can see a parametric sensitivity. You can change the different hypotheses and see how different decisions play a significant or minor role against this pandemic. And again, for the decision makers. In terms of also of lockdown time, I can remember that in France, the Ministry of Health said every day counts. And they were correct about that because by doing so, you can have a significant impact on the pandemic. Some decisions that are unpopular, but in the short term, but they have a big impact on the long term in terms of impact on the population. Sorry. One stop. Okay. So we can also go and see how pandemic variants and vaccination campaign play a role. You see here, for instance, the data. We introduced the English variant, which is the beta variant, on the impact of the contagion. And it's just a matter of following how the beta variant in the last year, in the winter of last year, 2021, played a role. And you see that you modify this system, and you see here, and also you can introduce an additional compartment, the vaccinated people that are removed from the susceptible one, or they are also vaccinated after some months once they have recovered. Okay, by doing so, it's just a matter of adding a further differential equation. It is very simple to be integrated numerically by means of our computers. And you see here how we can follow. This is the exogenous curve. This is an input curve. The number of vaccinations carried out in Lombardy, the same for Italy. And you see again that there is a good agreement between the model and the real data. Again, you can use these models for what-if scenarios in terms of, for instance, what is the impact of vaccinating at a higher rate? Asking, for instance, for the vaccination centers to increase of 5, 10% their efforts, or even working for a longer time, not only 8 hours, 10 hours, 12 hours on the population. What is the role? Again, you can see the parametric importance, and also anticipating the start of vaccination or the priority of different classes. In Italy, first medical doctors were correctly, and not only medical doctors, sorry, but medical people, workers were vaccinated, and then we moved to people with different priorities, and you can see the role played. Going to the conclusions, we have seen that mathematical models can help for what happened, what is happening, but even more important, what is going to happen on the short, medium, and long period, for sure. And this is a critical point. Pandemic data are very important. They are necessary for a multidisciplinary interchange, because people, experts of vaccines, of virology, of immunization, mathematicians, and so on, can work together, and this data, detailed, timely, shared, extended, sustained, and transdisciplinary, should be even more increased, and this is a critical point. And we can also carry out what-if scenarios in terms of understanding and anticipating, and also seeing and being prepared against new either COVID variants, SARS-CoV-2 variants, or also against the COVID 20X or 30X in the future. And to help also decision makers in terms of politicians and other people who have to take the decisions and make decisions. Thank you for your attention.
Thank you. Thank you for this different point of view for the day. And now, with the last presentation by Andrea Gori, from the University of Milan, the Polyclinic Hospital, with whom I had the pleasure to work in the last year on the pandemic. And he will tell us about how Lombardy region responded to this pandemic. You have 20 minutes.
Thank you. Thank you, Sergio. This is my disclosures. So the first question is, COVID-19, was it predictable? That's the first question you pose. And late in the 60s, this very excellent surgeon, William Stewart, said that the book of the infectious disease was closed because we had so high success that all the resources need to be switched in other emerging health problems. Unfortunately, happened the opposite, and in the last 40 years we have a lot of new epidemic events has been developed around the world, starting from HIV, HPV, ACD, Ebola, and so on. And if it's true, as Rino said before, that in a high-income country the infectious disease fighting is successfully managed, the infectious disease spreading around the world, mainly in low-income countries, remain a high risk for the planet health. And the answer to the question, if are there any factors that could increase and explain what is happening, I think that we can say that in the last 20 years, due to the great new deterioration of the globalization process, a lot of new factors, new challenges emerging that could really explain the emergence of COVID-19 epidemic, and also I think could explain the next future epidemic event. And I try to summarize some issue about that. Never on the story of the planet, people are living in metropolitan area. In the last 20 years, more than 20 cities with more than 15 million of people has been created with, of course, all the problems related to the management of the metropolitan area. 1.5 billion of people live in a slum with no water, no electricity, no health service. We travel a lot. We travel probably too much. The increase travel is something that we can observe every day, but we have to take into account also that not just human travel, but also food, insect, disease. They travel very fast. Second, the immigration process, of course, take a great role about the spreading of infectious disease, but we have taken account also, I want to underline the important, the condition in which the immigrant population are living in our country. This picture is not, has been made in the Lagos or Nairobi slums, but has been done in Saxarubra. Like it is very, in a suburb near to the Rome periphery. So I think we have to work a lot in order to better manage the condition of the immigrant population living in Italy. Climate change is probably one of the next challenge for the future generation. And I want to show some effect of the climate change here. Is the description of development of autonomous malaria in some island in Greece. That is possible because for the increase of temperature, the vector that transmits malaria can live without any problem in these latitudes. That's occur also in Italy. The tiger mosquitoes, Aedes albopictus, was not present in Italy till 5-8 years ago, and now is a frequent presence in every garden where our children are playing. That's 6 months ago. This is the Italian newspaper described the arrival in Italy of the Korean mosquito, resistant to cold, but is responsible, is a vector of the Japanese encephalitis. So we have to consider, because we know that the appearance of the vector is very high risk, because after the appearance of the vector, we know that the appearance of the disease is rapidly following. So we have to talk about preparedness. We talk about how to manage this situation and the changes in the world. We talk a lot, but we talk from many, many years. Here is Obama in the United Nations occasion of H1N1 flu. And he said that it's important, it's highly important to prevent and detect and fight every kind of biological danger. We talk about that, but in the fact that what we have observed before with the arrival of COVID-19 pandemic is all over the world is not prepared to manage such so strong epidemic event. Only 16 of the countries were fully prepared to identify and respond to a possible pandemic, too low. So now I think it's time to work, and we have to do it as soon as possible. As how Bill Gates says, we do a lot to solve immediately the problem, but mainly to keep it from happening again. So we have to invest, to think, but it is important that the time to invest and to think should be necessary now. We cannot wait. And this is an example of what we can do if we invest. The US invests 1.7 billion in COVID-19 vaccine, and in less than 2 years, we have the possibility now We have a successful vaccine that we can use to fight the pandemic. So never as before, we face global challenge, and never as before we need innovation. And that is the direction of Regione Lombardia, who in this time work a lot to build up a new multidisciplinary center for prevention and control of infectious diseases. In the previous talk, we underlined the necessity to improve research in diagnostics, research in vaccine, new therapeutic strategies, new IT investment, new IT implementation. So that is what Regione Lombardia want to do in the next future. Why Regione Lombardia? Because it's the ideal environment for research center. In Regione Lombardia has the best hospital network and research institute in Italy, high-ranking university, both public and private, and more than 20% of the economical power is located in Regione Lombardia. For the same reason, however, Regione Lombardia is a high-risk public health crisis. It has the highest population and population density in Italy, massive traffic, 3 different airports with high number of international events and intense international trades. So a new research issues to prevention, control, and coordinating the efforts against infectious diseases. A new innovation model in order to operate dual operating before and during public health crisis. A new center based on cooperation and partnership with national and international institutions. A new center to work to create network in Lombardy and outside Lombardy in all Italy. What we have learned from COVID-19 that is necessary to develop effective preparedness. We're talking about this a lot in this afternoon, strong coordination, excellent access and sharing of health data, said before, clear and timely communication strategies. And also because we know the COVID-19 will not be the last pandemic, as the Director General of WHO say, is better to be prepared and keep them to act together to the next epidemic. And we want to say before, we want to operate in some innovative mode before crisis and during crisis. Before crisis, we have to work a lot regarding preparedness. So basic and applied research, diagnostic, vaccine, new drug, monoclonal. We have a lot of work, not only regarding COVID-19, but probably regarding all the new possible infectious disease crisis as antimicrobial resistance. We have developed a preparedness plan, but we have also able to switch between operating mode to a decision-making mode to action. And during the health crisis, we have to put out all our efforts in advanced emergency and application of preparedness plan. So we have different issue and subtitle, of course, researches in infectious diseases, and create a network of infectious diseases, different institutions, epidemiology intelligence with the realization and data center for prevention, healthy community medicine in order to increase talk between the two different health systems. Training and multidisciplinary education, that's not only for the health people, but also for non-health professionals. Risk communication and community involvement, prevent flexibility, that's a very important point, mainly in Italy, where it's so difficult, as Rino said before, and pointed out the attention before, and how it's difficult to move rapidly from research to clinical setting. Emergency plan review, of course, the preparedness mean also the production of policy, and that could be help the decision maker to have the right position, which is the role of Lombardy region, of course, to try to be multidisciplinary and to encourage multidisciplinary in order to create a network which have connection, collaboration at national and international level between all, among all the stakeholders involved, public and private hospital, research institute, NGO, university, public and private foundation. And in conclusion, this slide has been already shown by Sergio. The question is if we are living a dangerous timeline. In the last 20 years, due to 3 different spillover, we observed the emergence of 3 different outbreaks around the world. And that's in the same time we have an increase of changes, a new challenge that are regarding our way to live, and we have to coordinate all the efforts in order to better manage all these future characteristics in order to be better prepared to ID event. And I think that the response to Region Lombardia to COVID-19 could be a great example for what we have to do, what is the direction in which we have to work in order to prevention and research and coordinate on all the efforts in order to be better prepared for the next epidemic event that will arrive in the future. So I want to thank all the people who are working with me every day at Policlinico, and of you, of course. Thank you for your attention.
Thank you, Andrea. The representation of this, I think we have been a bit long, and I will invite now, if there is any burning question from the audience, we can have 2-3 minutes for questions. Otherwise, I would invite Letizia Moratti for the closing remarks, followed by Mr. Cristina Messa for the closing remarks. Dr. Letizia Moratti, as you know, she's the Vice President, Region Lombardy. She's been the major, the most important person in the development of the center that Andrea just mentioned. And she's Counselor for Health and Welfare in the Region Lombardy. Please, Letizia, for the closing remarks.
Thank you, Sergio, and good afternoon to you all. As I anticipated, the contribution each of our speakers has brought to the table today is of very significant value. I have always been proudly claiming that healthcare system in Lombardy region is of excellence, and this also during the COVID pandemic. And also, I always highlighted the importance of our scientists and researchers who have often delivered activities and results of international level and relevance. And in front of the photograph that today debate leaves us, I want to thank Professor Lanzavecchia for presenting his research on lymphocytic clonality as an instrument to develop new therapies. I also thank Professor Abrignani, who through his testimony today has highlighted once again the importance of vaccines. The COVID experience, as rightly emphasized by Professor Baldanti, inevitably brought us to be engaged in the fundamental monitoring activity, which requires diagnostic tests that allows us to evaluate in depth each single case. As observed by Professor Rapoli, what is this experience leave us is a further teaching of history as previously occurred in US back in the 90s with the spread of infectious diseases. And the current pandemic also reminds us the importance of hygiene. Science and technology today offer us great opportunity to reduce development time. We saw the acceleration of vaccine development, which was something never seen before. And as represented by Professor Manca, innovation and digital models will be of fundamental support, added value in the challenges with which healthcare will inevitably have to face. Innovation is without doubt the key word, and we also heard it in Dr. Giuseppe Ippolito's speech. I believe that after hearing our speakers today, it is right to say that who best reacts to change wins. And this is the theme is also that it has also been highlighted by Professor Gori, who reminds us about the need to be extremely rapid. 2 years from when the COVID pandemic started, I wish to close this conference looking at the future with optimism, thanks to the hope that science has provided us. The battle of against infectious diseases continues. History and infectious diseases, which we came to know, show that the world was caught unprepared. This is the reason for wanting to create a national center for infectious diseases in the Lombardy region, a center which will work, as Professor Gori has highlighted, in cooperation with all the national and international centers and with the European Commission in order to avoid finding ourselves to re-challenge life expectation as we did in the previous pandemic phase. So thanks to all the contributions, and I wish to conclude with the greeting to Minister Messa, who will close the meeting today. Thank you to all of you.
Thank you, Dr. Moratti. And now the very final closing is by Cristina Messa. It's a pleasure to have her closing this meeting because Andrea and I have worked in the last year in creating this new center in Lombardy, and the people who interacted most with us were Beppe Ippolito at the Ministry of Health, obviously Tizia Moratti as the dominus of this new institute, and Cristina Messa as Ministry of University and Research. So thank you for closing this meeting, Cristina. It's your turn.
Thank you very much, and my greetings to all of you. It was I could hear a part of your talks, and it was a very interesting treaty on the COVID-19 and which lessons for the future. And of course, I particularly thanks to Letizia Moratti for being here and for having this very interesting and important work in Lombardy region and not only there. So I just would like to close the meeting reinforcing the concept of what is going to change now when we will be hopefully out of the emergency and everything actually has changed. The impact of the pandemic is impacting both time and space. Time, because the acceleration we are living today on everything, not only on the health system project and programs, but also on the daily life towards a more sustainable environment, countries on the digital transition, ecological transition. I mean, this acceleration has to be, let's say, transferred to citizens, and that is not easy, of course, because when you live in a transition time, you risk to lose aims and, let's say, long-term aims. The space, we know that particularly us as doctors, but also as scientists, that there are no borders. But probably the pandemic make everybody realizing on the fact that there are no borders, that there is some living body that doesn't care about borders. And so that, of course, is changing the way we look at the world, and is reinforcing the need for internationalization. So this strong impact is reflecting on many different issues, and of course I'm going to talk a little bit about those regarding our ministry, so research and higher education. Well, as for higher education, there are several changes, I would say. The first one is the fact that we are very much exposed to the need of creating and giving competencies to a large number of people. Certainly we need medical doctors, but we need also specialists. We also need nurses. We need also people that are not really simply classified, such as those needed for the social environment, for the social needs. And this, of course, is putting a lot of pressure on academia and on universities. And not only because we have to find the best way in order to give the right competencies to all the needed, the people who need it, but also because we might need to review also the way we do this in terms of content and in terms of architecture of our courses. Certainly the doctor of the future will be a little bit different than the doctor we created during the past 30 years. And this is a challenge for universities. Also, the impact of research is, you already said that, is very important. There is a strong need to accelerate the path from research to application and to therapy and cure. We knew this. I mean, when we created the research centers for translational medicine, for example, the RCCS, we already knew that we needed a strong link between research and application, between clinical needs and research innovation. But nowadays, I think that we also understand that this is not only a model where you put together biology, medicine, clinical medicine, therapy, and so on, but also you have new also profiles that are needed, like data analysis, informatics, engineering. So it's becoming more complex. As a complex problem, it needs a complex approach. And the acceleration has actually many backgrounds, many issues that need to be solved. For example, when we talk about researchers, well, we need to solve the problem, or let's say the need for different careers in research. We need a basic researcher as well as an innovators. We need base research as well as applied and clinical research. And the people who are involved and who are the actors of this type of research should have the same accessibility and possibility of careers. Also, we need a much stronger relation and networking between academy, health research centers, and industries. And this network has not been, let's say, put in enough relevance as is going to be now. For the recovery plan, you know that our ministry is very much working on creating these big networks, possibly national, but also local regional networks. But what is common among these different measures is that we want public and private go together, academy, research centers, and industry of the life science, for example, working together. That means not only transfer from research to business products, but also exchange expertise, exchange labs, exchange infrastructures, and exchange careers. And all of this has to be done with the right knowledge of what is happening across the world. We as a university have examples of very international universities in Italy and also examples of less international universities. We need to go back to the understanding that universities and research do not have borders, as I said at the beginning, and actually they are very important attractors of people, young generation across the world. Certainly we have in Europe the Erasmus program, but that is not enough. We need also to exchange professors, teachers, and researchers as much as possible, and to have this across our country. I want to make up two more points very briefly and then conclude. One is that when we talk about accelerating the results from research to application, we need also to work very much on rules and regulations. And this has been done, but it should be done more. We don't need only financial support. Rules and regulations are those that slow down the relationship between public and private, as well as the path from research to a product. And in this sense, the government has a big responsibility, because this is a work that can be done only working together at interministerial levels. And in fact, Beppe Polito was talking about how much our two ministries are working together in order to improve this problem. And finally, like Andrea Gori said at the end, we need different examples and also models in order to design the strategy for the preparedness concerning infectious diseases. In any strategy, I think that a common pillar of all the strategy should be science and innovation at global level. We can't think of having let's say a big program of preparedness without involving and giving the right space and importance and relevance to science and innovation. Thank you very much. It was a pleasure to be here with you.
Thank you, Minister Messa. I think now the day is over. It was a great pleasure for me and Andrea organizing this. For those who are here, now we start with the enjoyment. We are in the accent terrace. I don't know where it is. Is it nearby here to do? Downstairs? On the ground floor? Okay, so we move in the accent terrace just to enjoy the time we have in the day. Yeah. Thanks, all of you. Thank you.